Hi, Tam here. So today I'd like to talk about hydroxychloroquine. Now I didn't want to talk about chloroquine and hydroxychloroquine because I didn't want to fuel the current frenzy about these drugs, you know? The whole world is overly excited about this. Some people are losing their mind over hydroxychloroquine and chloroquine. Now, I didn't want to participate or accentuate the current frenzy on hydroxychloroquine and chloroquine. But something happened in the ER tonight, actually just 2 hours ago. So what happened is that today, right? This is the third time it happens now. But today, this woman comes in. So this woman is in the ER. She's not very sick. She's actually quite okay, you know. Doesn't have a fever. Only has a runny nose, and she says that she's got a headache, you know. So, first of all, there is a COVID-19 pandemic, yeah. The country is in a lockdown, is on lockdown. The message has been passed everywhere that if you just have mild symptoms of the common cold, man, you can go to a pharmacy, take some cold and flu medications, get tested if you want to get tested, but you don't need to go and crowd hospitals that are already crowded as it is, you know. But anyway, so she's in the ER and she tells me, right? And also I want to add that, you have to be brave to come to hospital for a runny nose, because hospitals right now are the most dangerous places on earth in terms of COVID-19. The one spot where you're most likely to get infected, wearing a mask or gloves or not, are hospitals. This is where all COVID-19 patients are going to end up. This is where all very sick people are. This is, even if all the disinfecting and all the hygienic precautions and, all the cleaners are doing such an excellent job. That's wonderful, cleaning and spraying and disinfecting constantly, but still, dealing with a respiratory virus, you have to be brave to just walk into the ER for a common cold or for some constipation or stuff like that, right? Just my 2 cents on the matter. But anyway, so the woman then, she's there in the ER, and I'm asking her, oh, hi, so what's the matter, right? And she says, she's a woman in her late 20s. She says, oh yeah, so I've got this runny nose and I've got a headache and I want to be tested for COVID-19. I said, yeah, but as you know, right, you don't come to the ER, you shouldn't come to the ER to get tested, right? There are some testing centers, there is a COVID-19 hotline, you can actually call them, they'll give you more information on where to get tested. By the entrance of the hospital as well, there's multiple signs telling you where to go to get tested, and specifically saying, please do not come to hospital to get tested because, we're trying to decongest this hospital. So she says, yeah, but I want to get tested here, but I also have another problem. Actually, it turns out she got tested 3 days ago. Turns out she's negative, but now she would like to get some hydroxychloroquine. But not only that, she went to see a general practitioner who did an influenza rapid test, and she was positive for influenza. So, number one, you're negative for COVID-19, you're positive for influenza, so clearly your symptoms are not symptoms of COVID-19, you have influenza, right? Be as it may, she said, no, I asked my doctor to give me a prescription of hydroxychloroquine and azithromycin because everybody knows that this is the cure for COVID-19 and I just want to have it with me, you know? And then she says my family doctor refused, right? So I told her, no, unfortunately, I'm not gonna give you some hydroxychloroquine. I'm not gonna give you a prescription of hydroxychloroquine or azithromycin. Number one, you do not have, you have influenza, not COVID-19. Number two, there is no evidence today, 19th of April 2020, that hydroxychloroquine treats COVID-19. And there is no evidence that hydroxychloroquine in combination with azithromycin treats COVID-19. And there is no evidence that chloroquine with azithromycin or without treats COVID-19. There is not even evidence that it makes you heal faster. So anyway, she wasn't very happy, she left, and you know, that's, like I said, that was the third time. The time before that, it was a perfectly looking, I don't want to say perfectly healthy, because who's perfectly healthy? We don't really know, right? I'm not perfectly healthy, you know. But let's say it was a man, an asymptomatic man, no symptoms, who waltzed into the ER and basically lied. And he said, hey, you know what, I've come to get a refill of hydroxychloroquine. I just arrived from an endemic area. Actually, I just traveled back from West Africa. I was on a business meeting there, but you know, because of the lockdown, I was kind of stuck there. And now I've managed to come back into the country. I was supposed to continue my chloroquine prophylaxis after leaving the endemic area, right? So 4 weeks after leaving the endemic area. So yes, I'd like to have some few doses here, you know. So I told the guy, okay, no problem, I understand. Can I see your passport, please? So he says, well, you know, why? I said, well, you know, I need to verify that you were in an endemic area. I mean, from what I know, there is a lockdown. There's absolutely 0 flights in or out of the country. So how did you just arrive now? I mean, you just, you know, I mean, not to say that I don't trust you, but I need to verify this, you know. And then he said, oh, okay, yeah, no problem. I don't have a passport with me. Let me just go home and I bring it back. I said, yeah, sure. So that was 3 days ago. He left, never came back, right? Now, this is just what happened to me, but there is a lot of doctors and pharmacists who have plenty of stories of people becoming quite upset and quite verbally abusive because they're not being given the miracle drug that is hydroxychloroquine, right? So doctors and pharmacists are being accused of, well, not so much pharmacists, because pharmacists will ask for a prescription from the doctors, but yeah, even pharmacists actually, but you know, doctors especially are being told that, you know, the criminals, you know, they are criminals. There is a miracle drug, there is a cure, and they are withholding the cure. You know, they're refusing to help the sick, you know, or those who could be potentially sick, right? And that's very sad, man. And all these accusations are made by non-doctors, non-medicals. Why? You know, because of some irresponsible politicians who are going on TV pushing, you know, the narrative that hydroxychloroquine in combination with azithromycin is the cure to COVID-19. It cures COVID-19, it improves the symptoms of COVID-19, it decreases the time in hospital. Basically, you know, it's a game changer. It's the ultimate medication against COVID-19. You have people going on social media who have absolutely no qualifications in the medical field. Zero qualifications. But here they are making irresponsible statements to the effect that, hydroxychloroquine in combination with azithromycin seems to be working. And that's a tragedy, man. When you have a sports personality or a TV personality or a politician, a head of state, all public figures, making statements like that, it's very dangerous and it's very irresponsible. Even worse, you have doctors, who are public figures, like Dr. Oz, such people, So you have doctors who are TV personalities who are going on TV saying that, yes, it seems that hydroxychloroquine with azithromycin works against COVID-19. All right, so this is what... So I just want to tell you the truth about hydroxychloroquine and azithromycin, right? And why most doctors, the greatest majority of doctors, are refusing to prescribe it to patients who are COVID-19 positive. So here we go. So this is the story. Quinine has been around for more than 100 years. It's been used primarily to treat malaria, or initially it was created as an anti-malarial, Chloroquine has been around for more than 50 years, and it's also an anti-malarial. Hydroxychloroquine has been around for a bit longer than 30 years, and it is also an anti-malarial. The difference between hydroxychloroquine and chloroquine is that hydroxychloroquine is thought to have less side effects than chloroquine. You could say that quinine, hydroxychloroquine, and chloroquine are of the same family, by and large. Now, when it comes to malaria, your chloroquine and quinine are no longer first line of treatment for malaria. They were for a very long time. But now, today, and for a number of years now, there is such an increase in the resistance to chloroquine and quinine that is no longer first line of treatment. If you travel to an endemic area, in Africa or in Southeast Asia or anywhere else where there is malaria, the first line of treatment today are ACTs. ACT stands for artemisinin combined therapy, right? So if you go into a malaria area and you get malaria, most probably they will give you an ACT, right? So that's artemisinin combined therapy. So if you get malaria in an endemic area, let's say you're going on a safari in the Serengeti, or you're going to climb the Kilimanjaro, or you go into an area where there is malaria, right? They will put you on ACT, artemisinin combined therapy. So usually it's going to be something like artesunate with amodiaquine, or artesunate in combination with mefloquine or something else. There's a list of recommendations by the WHO. Quinine or chloroquine are only recommended when there is proven susceptibility to quinine, all right? Or if you're a pregnant woman in the first trimester of pregnancy, because then artemisinin, due to their side effects, will not be first line. So then first line becomes, if you're pregnant in the first trimester of pregnancy, first line becomes quinine or chloroquine. If there is no resistance to it where you are, right? So from the mosquitoes that give you malaria when they bite you, there's 5 different types of malaria. You've got your Plasmodium malariae, Plasmodium ovale, Plasmodium vivax, Plasmodium knowlesi, and the most dangerous of them all, Plasmodium falciparum. That is a death sentence unless you go on treatment. Right? So if you get Plasmodium falciparum, which is very prevalent in Africa, that's a killer. You need to get medication, either ACTs, artemisinin combined therapy, or quinine or chloroquine. Now, hydroxychloroquine is not only used as an antimalarial, it's also used for other diseases, right? So it's also used as an immunosuppressant. It's used not as first line, but it's also used for rheumatoid arthritis in some patients, depending on the indications. It's also used for SLE, systemic lupus erythematosus, not as first line, but for certain patients, having certain criteria for it. It's also used for Whipple's disease in combination with doxycycline. It's also used for Q fever, when you have a persistence of Q fever, again in combination with doxycycline. All right, it's used for different diseases as well. I think it's also used for Sjogren's disease, Sjogren's syndrome, sorry, Now, it's not uncommon for a drug designed or manufactured or created to treat primarily something specific like chloroquine, hydroxychloroquine for malaria is used for something else. No, it's happened many times before. Many drugs can be used off-label. A doctor has the right and the authorization to use any medication for any medical condition if he or she has evidence that it works. So there's nothing wrong with hydroxychloroquine being used for different things like it is, But now here's the problem, or rather here's the story. Hydroxychloroquine for the last 30 years, or maybe even longer, has always been one of the first drugs to come to mind or to be mentioned when there is a new virus, a novel virus that nobody has ever seen before. There will always be somebody somewhere in the world that will say, hey, hydroxychloroquine works. So for doctors, it's nothing new, this whole saga about hydroxychloroquine and COVID-19. Nothing new at all. In the 1990s, there were some experiments on chloroquine against against HIV. There were some conflicting reports. Some were saying that chloroquine works very well against HIV. Some tried to replicate that experiment and said no, chloroquine doesn't work so well. And there was a bit of a polemic there. People were divided. Ultimately, it was not part of the protocol. The whole thing it carried on. It was never really abandoned. It carried on until in the 2000s. It carried on in the 2010s. And in 2015, in June 2015, just 5 years ago, there were new experiments done on chloroquine as treatment for HIV. And they did some tests. And these tests showed that chloroquine seems to be working well against HIV, And then the main difference in those experiments were that, in high doses, they had positive results against HIV. But in lower doses, no improvement. And by high doses, from what I read, they were talking about 800 milligrams a day, doubling up to 1,600 milligrams a day. So those are very high doses. There's a myriad of side effects that you're exposing your patients to, And then, but they were saying that, it works. And then other people repeated the same experiment at the same doses and then said that, no, but there's no difference. In fact, some of the patients seems to be getting worse. And then the whole discussion there became, oh yeah, but some of the patients are on ARTs, antiretroviral therapy, for HIV, and others are not. Up to now, people are still studying the matter, but now currently the debate is chloroquine in the treatment of HIV, with ARTs, with no ARTs, in high doses, or in normal doses, or low doses, so those are debates, So this chloroquine, hydroxychloroquine debate has been going on for a long time, since the 90s already, Dengue fever. So when dengue fever became, there was a bit of an epidemic of dengue fever, some people said, chloroquine, it works. All right. So in vitro, meaning in a test tube or in a culture dish, it works. So they did experiments in vitro, in a test tube, and some researchers had some positive results against dengue fever. But when they repeated the same study on animal specimen, on animal subjects, right, there was no improvement. So sometimes that's the thing as well, you can test something in vitro and you get very good results. But in vivo, in a human being, it's a completely different story. So now that brings us to chikungunya fever. When chikungunya fever, because there is no cure to chikungunya fever, some researchers said, guess what? There is a drug that seems to be working against the chikungunya virus. Which one? Hydroxychloroquine. So there was an experiment, a study done on 54 patients in the French Réunion. All right, 27 patients were control patients. Right, so they were on placebos, right, and then 27 other patients were given hydroxychloroquine. That's a controlled study, yeah, and they found out that hydroxychloroquine, not in vitro, but in patients, used on patients, seems to be working. The group that was given hydroxychloroquine did better than the group that was not given hydroxychloroquine. So that's great news. And it was exciting news at the time, But what they found out is that later, much later, at day 200, so we're talking about more than 6 months later, right? At day 200, the group that was given hydroxychloroquine was now getting worse. They had worse arthralgia, meaning pain in the joint pain, as compared to the group that was in placebo, that were not given hydroxychloroquine. So that was a problem now, because here's a drug that seems to be working against chikungunya fever, but now at day 200, those patients seem to be getting worse. So that's a problem as well. Day 200 is very, very far. It's 6 months and a half. Now, Zika fever, some few years ago, you remember when Zika fever was on the news all the time. I think it started around Brazil. I need to verify that, excuse me for that, but I think it was Brazil, around Brazil, and then it spread in South America, Central America, North America, and then, many other countries in the world. There is no cure for Zika. Zika, the Zika virus is a flaviviridae virus, just like the dengue fever virus, So there's no cure for it up to now. And people are trying really hard to find a cure. Zika is most dangerous for pregnant women, because women who get Zika virus, themselves, they will not die from the disease, but their babies will be born with deformities, And one of the major deformities of babies born of Zika infected mothers is that they get macrocephaly, so they get born with a head that's much, much smaller than normal, and other deformities as well, So people have been struggling to find a drug, to find a cure, to create a drug, to manufacture a drug. But some researchers found out that there is one drug that seems to be working against Zika virus. Hydroxychloroquine. So in January 2018, an experiment was done, a study was done. So that was January 2018, so that's quite recent, that's just 2 years ago. I must say, from what I've read, from that study that I've been reading, all right, the results are quite promising. Hydroxychloroquine seems to be decreasing placental transmission, or at least viral load from the mother to the placenta to the fetus, So they're still studying it. It's 2 years now. They need to study it more, do more research. But so far, that's where they are, But it takes a long time. You can see all these studies I'm mentioning, they're taking a long time. They're taking years, actually, It's not easy, It's not easy because you have to make a drug safe. That's the most important tenet of medicine. Do no harm. You have to make the medication safe. It's best not to rush into things. It's best not to panic. People are dying. People are dying of dengue fever. Babies are being born with macrocephaly and other deformities due to Zika virus. But we can't rush into things. Things have to be done according to protocols that are established, guidelines and all the stuff to make things safe as possible before dishing these things out to the population, right? So that's the history of hydroxychloroquine, so that you know where doctors are coming from. You know where we're coming from when we are very reserved about just prescribing it to people. You can understand that's the history of chloroquine and hydroxychloroquine. It will be catastrophic to rush into things and prescribe things that are not proven to work, only for that medication or that combination of medication 6 months later, 1 year later, to be proven to be killing people. That brings us to today. There's a lot of desperation, and there is a race for a cure. It's a sprint for a cure. There is many different options that are being put on the table now. The best option so far is a drug, an antiviral drug called remdesivir. Remdesivir has been created by Gilead Pharmaceutical. It's very promising. Currently, they are on phase 3 already, Apart from that, I think the number 2 contender to the throne, The number 2 contender is convalescent plasma. You take the blood of patients that have recovered from COVID-19. So, they are in convalescence. On PCR testing, there's no more viruses. The virus is no longer in them, but they have antibodies to the virus, because they fought the disease. The immune system created antibodies. Like most people who will get, in fact, all people who will get COVID-19 and then recover, they will have the antibodies against the disease. So then, basically, you take the blood of those people who had the disease but are now healthy, right? But have those antibodies. You take this blood and you transfuse it to people who are now sick or seriously sick. And then those antibodies are going to fight the virus in the patients that are sick. All right. A small study was done. It's a study of 5 people, so it's very, very, very small. It was 5 critically ill patients, ICU patients, deteriorating. They were all 5 were given convalescent blood. Within 3 days, their temperature normalized, which is, for all 5, I think, No, for 3 out of 5. Yeah, the temperature is normalized. But more importantly, by day 12, all 5 improved, and then progressively, I think 3 out of 5 were able to be weaned off the ventilator, So that's the story of convalescent blood. It's only 5 people, a very, very small study. There's some complications as to doing this blood transfusion in the chosen patients, After that, another promising drug is tocilizumab. So tocilizumab is, so those are biologicals, right? So tocilizumab is an IL-6 receptor inhibitor. IL stands for interleukin. So tocilizumab is an interleukin-6 receptor inhibitor. It has not been created just now, but it is currently being used for CRS, cytokine release syndrome. It's also used in rheumatology for rheumatoid arthritis. They're doing some experiments on it with regard to SARS-CoV-2 virus, the COVID-19, the virus that gives you the COVID-19 disease. And so far, it seems to be promising, let's wait and see. There's many other studies as well, but these are like the biggest ones so far, or the more popular. But, I think there's more than 100 studies right now in countries all over the world. People are trying to find a cure and which medication works the best. That brings us to hydroxychloroquine and chloroquine. As I mentioned before, hydroxychloroquine, chloroquine, they've been used before. They've been tried against different viruses for many years in the 1990s. Studies done on HIV. Later on, studies have been redone on HIV. Studies have been done on dengue fever. Studies have been done on chikungunya fever. Things were getting better at first, worse later. Studies have been done on multiple diseases. Whenever there's a new virus, there will always be someone bringing hydroxychloroquine and chloroquine as the cure. So now, this year, I think it was in February, in China, some researchers were testing hydroxychloroquine in vitro in test tubes against the SARS-CoV-2 virus, this novel coronavirus. Sorry, did I say that the Chinese scientists tested hydroxychloroquine or chloroquine? They tested chloroquine. So they tested chloroquine on their patients, and unfortunately, I could not access the research. The little I could access was not very forthcoming. It was not very open. They just said that, they tested it in vitro and there was some success, and then they've tested it in animals with some success, and now they're using it in humans with some success. And now the Chinese CDC, as the Chinese Center for Disease Control, has recommended it for use in the human population in China. But the study itself, when I read the paper, it was, the methodology was not proper, to be honest. So there was a big question mark there. And it seems that there is no clinical benefit to hydroxychloroquine used on patients with COVID-19 from the research. No clinical evidence that it works. Following this study in France, Professor Didier Raoult of Marseille did his own study, his own experiments, his own research on hydroxychloroquine in combination with azithromycin. So what they did is they chose hydroxychloroquine, and the advantage to that is that hydroxychloroquine has less side effects than chloroquine. All right. So they chose a group of patients, 42 patients in total, and some of these 42 patients were on hydroxychloroquine, some were on hydroxychloroquine and azithromycin, and some were the control group, so they were not given anything. All right. And the conclusion of that study, of these 42 patients, were that of the 6 patients, 6 out of the 42 that were treated with hydroxychloroquine and azithromycin, so it was hydroxychloroquine 600 milligrams a day orally, so 200 milligrams 3 times a day for 10 days, in combination with azithromycin, 500 milligrams on day 1, and then 250 milligrams a day. So the conclusion was that the 6 patients treated with hydroxychloroquine and azithromycin all improved. The end point was day 6. So they're going to be tested over 6 days. So the way they were doing it is hydrochloroquine was given at 600 milligrams a day, every day, 200 milligrams 3 times a day orally, and azithromycin was given at 500 milligrams orally on day 1, followed by 250 milligrams orally a day, every day. The end point of the research was day 6. And every day they will test their viral load by nasopharyngeal swabbing, and then they would PCR those nasal specimen, those nasopharyngeal specimen, and look at the viral load, So by day 6, they found that all 6 patients out of the 42 that were treated with the combination of hydroxychloroquine 600 milligrams a day and azithromycin 500 milligrams on day 1, then 250 milligrams a day, all 6 of them had a viral load that was negative. That's wonderful news, But here's the problem. It's 6 patients out of 42. Now, when you read the paper, and most doctors around the world have read the paper, and most doctors are not happy about the paper, including myself, because the methodology of the study, unfortunately, was not proper. That's the truth, When you do a research like that, there are certain parameters that needs to be respected for your study to be not only published, but acknowledged and ratified, if you will, by your peers. So your peers have to review your study, your peers around the world, and agree with the study. That's a peer-reviewed study. So the parameters of a study is that, first of all, it has to be random. If you want a high-quality study, it has to be a randomized trial. Your test subjects have to be randomly chosen. And then, so that's a randomized trial. Your control group that is going to receive a placebo, not the medication, and your test group that is going to receive the experimental drug has to be randomly chosen. A randomized controlled trial, RCT. But if you want your study to be of an even better quality, not only is it going to be a randomized control trial, but you're also going to make it blind. Now, a blind study is a study where the patients have no idea, the test subjects have no idea as to whether they're getting the placebo or the real drug. And for those who don't know, I'm talking about placebo. It means, I'm doing a test with 10 people. And I'm going to give these 10 people remdesivir to treat them from the COVID-19 that they have. 5 of them are going to receive remdesivir. The other 5, I'm going to give them a placebo, meaning I'm just going to give them a substance, let's say water, right? Water in a syringe instead of the medication. So 5 of the 10 will get the medication, the injection every day. The other 5 will just get water, but injected in the blood every day. But they've got no idea, these 10 patients have no idea as to what they're getting. As far as they're concerned, they're all getting the real thing. Because the placebo usually looks exactly like the real thing. So if it's injections, you will find that they've taken the original medication and they've just removed the active ingredients. So they've left the non-active ingredients. It looks the same color, same formation. There's no way of knowing. It's a blind study. And if it's tablets, if it's oral medication, same thing. The real medication looks exactly the same as the placebo. So the placebo could be a sugar tablets, for instance, or something else. But it will taste the same as the real thing. Or if there's no taste to it, then there's no taste to it. But there's no difference. So the test subjects, the patients, do not know if they're receiving the real thing or a placebo. So that's the definition of a placebo, Basically something that has no effect, like a water tablet or a sugar tablet or whatever, or like water injected. I've given placebos before, but anyway, so that's the difference between placebos and the real drug. So a blind study, it means the patients have no idea as to who's getting what. And the advantage to that is that if I'm telling you that here, I'm giving you remdesivir injections, and it's remdesivir, even if it doesn't work, the fact that that there is an experiment on a drug that is purported to be curing COVID-19, the fact that that already, this bias in your brain, will have an effect, might have an effect, and you might start getting better. And you see it all the time in the ER, in hospital, when somebody is addicted. A good example, I had a patient, he was addicted to something called Akhenaton, and he would come in the ER and have the shakes and said, I need my Akhenaton. And I would just give him a placebo, so I would take the vial of Akhenaton, and then I'll have a vial of saline water in my hand as well, and I will just put the syringe into the water, basically, draw it. He would think it's the Akhenaton. I'll inject it to him. As I was injecting it, it was quite amazing. You would see the guy, he would just stop shaking. And you say, thank you so much, doctor. Thank you so much. You really saved me. He was a psychiatric patient. Because he believed I was giving him the real thing, his symptoms would just disappear. And then after a month, he would come back and we would repeat the process. So that's why you want your study to be blind. So that, patients don't know what they're getting. And there's no way for them to just get better because they believe they get the real thing. So that's a proper way of doing a clinical trial. Randomized controlled trial, but it also has to be a blind study. The study of the French professor was not randomized. So it was not a randomized controlled trial. And that's a big problem. And on top of that, it seems that it was not a blind study. Now, if you really want your study to be of the highest quality, not only you're going to make it a blind study, but you will make it a double-blind study. A double-blind means that your patients don't know what they're getting. Are they getting the placebo or are they getting the real thing? But the doctors conducting the experiment, giving the medications, don't know what they're giving as well. So I can have my 10 patients in the ward, they've enrolled in the study, they know that they might be getting a placebo or they might be getting the real thing. They're getting the injections every day. They have no idea what they're getting. But the doctors or the nurses or the people giving the medication as well, have no idea what they're giving. Only me, who is the principal scientist conducting this experiment, will know who's getting what. And I'm going to document this every day because I need to document it to know that, these 5 patients are getting the real thing, these 5 are getting the placebo, But the people to whom I'm giving the syringes, they've got no idea what I'm giving them as well. So that's a high quality study, and that's how it should be, a double-blind study. And the reason you want to do that is that you want to make sure that the nurse or the person giving, the doctor, the person giving the injections or giving the oral medication will not have some biases as well, and maybe feel sorry for the patient and tell the patient, you know what, to be honest with you, you're just getting a placebo here. Or, all is good, you're getting the real thing, so you should be getting better soon. No, you don't want that. So it's a double-blind study. So a study of the highest standard will be a DBRCT. Double-blind, randomized, controlled trial. Unfortunately, the French study of that eminent professor was done in a rush. The methodology, unfortunately, was mediocre. And the conclusions of the study cannot be accepted, unfortunately. And then the other problem is that, it started with 42, but the study actually talks about 36 patients. Why? Because 6 patients were dropped off the study. All right, so it's 42 patients. 6 patients were removed from the study. Why? Because 3 of those 6 deteriorated and had to go to ICU. And now they had to go to ICU and they were treated, differently, so they were dropped. But they shouldn't be dropped because they might have been given the hydroxychloroquine and azithromycin and then ended up in ICU. So we should know. But we don't know what they were on or if they were on anything. And then the other 3, they dropped out of the study by themselves. I think one absconded, decided to leave the hospital. Another one had side effects, I think nausea and vomiting. And the last one died on day 3. Did he die? Was it one of the patients? Was he or she one of the patients on hydroxychloroquine, or was it a patient that was on no medication at all, or a patient that was on a combination of hydroxychloroquine and azithromycin? So these are questions that we need answers to those questions. And then of the 36 remaining, right, of these 36 patients, 22 of them had upper respiratory tract infections. 8 of them had lower respiratory tract infections, and 6 of them had no symptoms. They were completely asymptomatic. 22 upper respiratory tract infections, 8 lower respiratory tract infections, and 6 asymptomatic. In fact, the patients that were put on azithromycin were put on azithromycin once their condition deteriorated from upper respiratory tract infection to lower respiratory tract infections with pneumonia. Many questions here. At what stage? In the study it says that this was day 0, started at day 0, started at day 6, started at day 5, at day 2. But if you're asymptomatic when the study begins, but you're positive for COVID-19, things can go two ways. With no medications at all, it's either your immune system is going to fight the disease, you get the antibodies, you're asymptomatic, you don't even know you have the disease like so many people, and then you're fine. Or you could be asymptomatic and then become symptomatic. And there's two other options. You can be asymptomatic, you become symptomatic, and then your symptoms get worse, so much worse that you have to be admitted, hospitalized, and given serious medication, and possibly even go to ICU. Or you just deteriorate a bit, flu symptoms, 4 or 5 days, maybe less, and then you become okay. But for most people in the world who get COVID-19, the COVID-19 infections, yes, they get flu symptoms, maybe a cough, rhinitis, sinusitis, stuff like that, fever, and then they recover with no medication. So their viral load picks up and then decreases once they've got the antibodies, And what I'm saying is that if you were in that study asymptomatic or with just upper respiratory tract infections, chances are that by day 6, your viral load, your nasopharyngeal swabbing to calculate your viral load will be high or will be positive because you're asymptomatic on your way to become symptomatic. But if you are in the study where you are already having a lower respiratory tract infection and you're already on azithromycin because you have a pneumonia, chances are you've already progressed into the disease for quite some time, and your viral load now might be in the decrease, so that 6 days after, your viral load could be negative regardless of you getting azithromycin and hydroxychloroquine. And because of all these question marks and all these methodological failures, the only thing that study tells us is that there's zero proof that hydroxychloroquine and azithromycin works better than, say, paracetamol. No proof. And that's the reality. And a lot of people are refusing to accept that. And a lot of people are insulting doctors or refusing to give them hydroxychloroquine or azithromycin. And it's a shame, It's a shame when you have non-doctors, non-medicals all over the world who are becoming so aggressive and who are actually calling doctors criminals because we're refusing to give them that miracle drug that they've seen on the news. It's a shame because do the research, man. Do the research, educate yourself, trust your doctors. It's a doctor, and that it's a shame. But I also understand, when you have head of states, presidents, who are actually pushing for this hydroxychloroquine, azithromycin cocktail, people are confused. You at the end, you think there is a conspiracy theory somehow that people are. Anyway, I just wanted to explain that to everybody. So far, and I think every single doctor in the world would be so happy if it was proven that hydroxychloroquine and azithromycin works and cures patients. I'll be so happy, man. Let's give it to everybody there and cure the disease, and that's it. But unfortunately, there's no evidence that it works. There's no evidence that hydroxychloroquine and azithromycin works better than paracetamol or a sugar pill or a glass of orange juice. There's no evidence. But what we do know is that hydroxychloroquine has some side effects. So one of the major misinformation about hydroxychloroquine is that because we've known that drug for so many years, right, for decades, we've established that it's a safe drug. All right, so you've got doctors going on TV, public figures, and even a certain head of state I saw on television declaring that no, hydroxychloroquine is safe. It's as safe as any drug, because we've been knowing it for decades, tens of years. And basically, we've given it to, it's been given to so many millions of people around the world. It's a safe drug. Yes, it's been given to millions of people who've had malaria or have traveled to malaria endemic areas, and hundreds of thousands of other people with other medical conditions as well, But like any other drug, hydroxychloroquine can have some potentially deadly side effects. So there is some precautionary measures that one must take before, actually going on a course of hydroxychloroquine, And just to emphasize my point, when you go see your doctor and your doctor makes the decision to start you on a course of hydroxychloroquine or chloroquine, there is a reason why your doctor is going to perform an ECG before putting you on the course. And that's because hydroxychloroquine and chloroquine can cause arrhythmias, dangerous arrhythmias, meaning they can change the rhythm of your heart. And think about that, there isn't too many drugs that your doctor is going to prescribe to you, but before giving you that prescription, will perform an ECG, an electrocardiogram. All right? When's the last time that you were prescribed an antibiotic or an antifungal or an antiviral, an antibacterial, and your doctor said, let's do an ECG before I give you the medication. So the fact that this is done for hydroxychloroquine tells you that it's actually a dangerous drug and one has to be very careful with it, So yes, it's established to be safe, but it's not that safe. It can still kill you, Now, hydroxychloroquine and chloroquine can precipitate a condition called a long QT syndrome, So basically what they can do is they can prolong your QT interval in your heart. What's the QT interval? Let me put it this way, right? So your heart muscle contracts and relaxes forever. It never stops. The day your heart muscle stops, that's the last day of your life. All right. So your heart muscle from the time you're born to the time you die will contract and relax forever. Sometimes a bit faster, sometimes a bit slower. You know? It's able to do that by electricity, right? So there is some electrical conduction in your heart. You know, your heart is a pacemaker, actually, you know? It generates its own electricity. It's a magical divine phenomenon of life. You know, not just the human heart, but the heart of any living animal. There is a pacemaker that just automatically starts at the beginning of life and then keeps on beating until you die. But anyway, let's not stray away from the topic. So the way your heart muscle does that, this contraction and relaxation, it's by the electrical conduction going into the heart muscle. The representation of that electrical conduction in your heart can be drawn on a piece of paper, and that's your electrocardiogram, your ECG. So I'm sure you've seen on Grey's Anatomy, on ER, on all the medical shows, Chicago Hope, back in the days, and any medical picture, You've seen an ECG. Some people I've even seen some people with an ECG tattooed on themselves, So an ECG, it's a line. Usually, in movies, when you're dead, they will show you a flat line on the ECG reading, Although it's never a flat line, the only way you're going to get a flat line is if your machine is not tracing anything. So there's a line, and that line has some waves. You will see some waves on the line, So that's your ECG tracing. And you have a P, Q, R, S, T, U. Sometimes the U is not there. It's perhaps less important than the P, Q, R, S, T, And the P means something, the Q means something, the R, the S, the T, And that's mirroring the depolarization and repolarization of your heart muscle, So now, when we talk about your QT interval, your QTC, we're talking about the distance between the Q wave and the T wave. That QT interval, that QT interval, the electricity is passing through it at a certain speed. So the QT refers to your ventricle and the electrical conduction that causes your ventricle to contract, right? To depolarize. And then repolarize, to contract and relax. So there is electricity going through it, it contracts, and then it relaxes, and then it contracts again, and then, So the speed of the electricity passing through that QT interval varies between, in humans, it varies between 380 milliseconds to 480 milliseconds. So there is 100 milliseconds difference depending on your age, and your gender. For a little infant, a QT interval of 380 milliseconds to 400 milliseconds is acceptable, For a young 6-year-old little boy or girl, 420 to 430 milliseconds is acceptable. Now for adults, depending on whether you're a male or female, your QTC will be between 470 60, 460, 470 milliseconds to 470, 480 milliseconds at the upper ranges, Now, I'm saying this to say that hydroxychloroquine is known to increase that prolongation prolongation, to increase the QT interval. So it's completely possible if you're sitting at a QTC of 480 milliseconds in your normal state, just by taking hydroxychloroquine, you could be pushed to 490 milliseconds and even 500 milliseconds. Now, 500 milliseconds is the cutoff time that most cardiologists will take, meaning if you're at more than 500 milliseconds, your cardiologist will be very concerned, and then more tests will be done, other tests will be done, right? And that's why it's important to do an ECG, because if you have a long QT syndrome already and you take hydroxychloroquine, you could die. It can be a dangerous drug. You see, hydroxychloroquine can be dangerous, Now, what happens if you take hydroxychloroquine and your QTC goes beyond 500 milliseconds? So above 500 milliseconds, your cardiologist will be worried because you can be pushed into an arrhythmia, and a dangerous arrhythmia at that, a ventricular arrhythmia, a ventricular tachycardia, meaning your ventricle. Remember, the QT interval is a measure of the electricity in your ventricle. All right, so now you've got a long QT syndrome. So your ventricle goes into a ventricular tachycardia. So your ventricle contracts faster. All right. Now, a ventricular tachycardia, if you have a ventricular tachycardia that is stable, meaning it's less than 150 beats per minute, and you don't have any symptoms such as hypotension or hypertension, dizziness, shortness of breath, and all that stuff, then it's a stable ventricular tachycardia. It is not a life-threatening emergency. You just go to the ER because you have palpitations. We do an ECG. You've got a ventricular tachycardia, and we convert you. We can chemically convert you. With some drugs such as amiodarone and others. Or if time is of essence, we can do an electrical cardioversion. That means giving you an electrical shock to put you back in rhythm. But what I want to tell you is that a ventricular tachycardia, due to a prolongation of your QT interval, maybe I'm being a bit too technical here. Let me just say this. You take hydroxychloroquine, you get a ventricular tachycardia. Hopefully not, but if you do, the danger of that ventricular tachycardia is that because of that long QTC, that ventricular tachycardia could be a polymorphic ventricular tachycardia. And that polymorphic ventricular tachycardia, because it looks like a torsion on ECG, it's a French name, it's called a torsade de pointe. Or as some people would say, a torsades de pointes. Most people will call it a torsade de pointe. That's okay, that's fine, And that's the danger, because a torsade de pointe, it can convert to normal I mean, a torsade de pointe, meaning a polymorphic ventricular tachycardia, can convert to a monomorphic tachycardia, spontaneously. And it could even convert back to a normal rhythm spontaneously. But a real danger is that a torsade de pointe, that arrhythmia, can continue and become a ventricular fibrillation. So your ventricle goes from beating faster to just beating so fast and so irregularly that it just fibrillates. It's just trembling. And by the time your heart does that, it's a death sentence. The only way you're going to come back from a ventricular fibrillation is by having somebody jumping on your chest and starting CPR. When you go into a ventricular fibrillation, you have some few minutes before that fibrillation goes into a complete cardiac arrest. So I also want to add that this QT interval prolongation that may be increased with hydroxychloroquine in itself, it's not a major issue. I mean, suffering from congenital long QT syndrome is not an absolute contraindication to receiving hydroxychloroquine. So that's not really the problem here. The problem is that azithromycin, one of the side effects of azithromycin is also QTC prolongation. So now you have two drugs, and both can give you a QT interval prolongation. And you combine them together as your form of treatment. Now that's a problem, because now the risk, all of a sudden the risk is increased. You have accentuated the chances that your patient might go into an arrhythmia, and not just any arrhythmia, but a polymorphic ventricular tachycardia, a torsade de pointe. And that's a problem. Now, I'm not a cardiologist myself, right? But, I would love for a cardiologist to make a video and give his or her views on the combination of azithromycin and hydroxychloroquine with regard to long QT syndrome or QTC prolongation. That would be interesting. So that's azithromycin's got some side effects, hydroxychloroquine's got some side effects, but they both can prolong your QT interval, and that's a problem if you're going to give them in combination. There are other side effects to hydroxychloroquine, but those are side effects that you're going to be exposed to in the long term. So if you're taking hydroxychloroquine for a year or more, for autoimmune diseases, RA, SLE, Sjogren's and things like that, then, you have to be wary of those side effects, And those side effects are, for instance, psychiatric disturbances, ocular toxicity, irreversible retinal damage, so if you ever had some retinal problems, some retinal disease, retinal detachment, I mean, that's an absolute contraindication to getting hydroxychloroquine, And then with your skin psoriasis, if you're a patient with psoriasis, you risk an exacerbation of your psoriatic plaques, In the long term, in the short term, I'm not sure, to be honest. I would have to see what dermatologists have researched about that. So those are some of and then there's porphyria, and there's there's a list of others, But the thing of main concern for me is that, both azithromycin and hydroxychloroquine can prolong your QT interval, and that is very dangerous, Now, if you're gonna give it to a hospitalized patient, I mean, that's much better because you can control them better, you can do daily ECGs or even 12-hourly ECGs or 6-hourly ECGs, or just put them on telemetry, and then observe them, if you feel that, there is a greater risk for your patients to go into an arrhythmia, And then, yes, you must also do a CBC, FBC, and then monitor the platelets, the white cell count, because hydroxychloroquine can give you a thrombocytopenia or a leukopenia, so you have to be aware of that, And then what else? Yeah, so these are the major, the most common side effects. I think there's a list of others, but these are the most common side effects. So normally when you prescribe hydroxychloroquine, you want to do just a quick eye exam, look at the cornea. The cornea can be affected as well, the cornea, the retina, do an ECG, look at the heart, we focus on the QT interval, and look at his or her dermatological status, is there any history of psoriasis, active or, that were there in the past, and that's and then do a CBC, look at the white cell count, look at the platelets, because of the thrombocytopenia, Is there a history of psychiatric illness? Is the patient on psychiatric medications, So all those things, like I said, when your patient is hospitalized, you can take care of all these things, you can monitor your patient well, put your patient on telemetry, it's easy, But when your patient, like in the study, the French study, some patients just had an upper respiratory tract infection, some were asymptomatic, So these are patients that are just gonna go to a family doctor. Oh, look, so I was diagnosed with COVID-19, and then you put them on hydroxychloroquine and azithromycin, and that could be dangerous. So you have to be aware of that, before trying to get some hydroxychloroquine on the black market, over the counter by some kind of, type of deal with certain people, Be very careful, it can be dangerous, right? But anyway, it doesn't have to come to that because it doesn't work so far, right? And then one last thing actually, is that some people, I've seen some doctors on social media, and even on TV actually, I saw some politicians as well, saying that, but the FDA has approved hydroxychloroquine as a form of treatment for COVID-19. Now that's incorrect. You see, that's misinformation here. That's not true. The FDA has not said anything with regard to hydroxychloroquine and COVID-19. So what the FDA did is that they approved something called an ANDA, abbreviated New Drug Application, for hydroxychloroquine, 200 milligrams tablets, Plaquenil. So this abbreviated New Drug Application, basically it's to fast forward the supply of hydroxychloroquine in the market in the US, because they had noticed that there was an increase in the demand for hydroxychloroquine, surprisingly. and then yeah, so they did an ANDA, and now I think everybody saw the president of the US saying that, we have 21 million tablets of hydroxychloroquine, or 21 million doses. It was unclear what does it mean, doses, tablets, packs, yeah, so that's the situation, That is not to say that the FDA has issued a statement to say that yes, hydroxychloroquine is the treatment of COVID-19. No, they haven't said anything like that. In fact, there were some specifications and some point of clarifications in their statement, and they did say that yes, we are approving, so they approved an ANDA for hydroxychloroquine 200 milligrams tablets, specifically for, number one, uncomplicated malaria. And they mentioned Plasmodium malariae, Plasmodium vivax, Plasmodium ovale, and Plasmodium falciparum. Plasmodium knowlesi was not mentioned. I'm not sure why, And two, for SLE, systemic lupus erythematosus. And also for chronic discoid lupus erythematosus, And three, finally, for rheumatoid arthritis. And they did mention that, the one has to be very careful with the side effects, And they mentioned, look, I'm going to put the paper in the statement in the video. I don't remember it by heart, but they did mention some of the side effects, like QT interval prolongation, cardiac toxicity, ocular toxicity, irreversible retinopathies, psoriasis, exacerbation of psoriasis. I'm not sure if porphyria was mentioned, but basically things like that. So just to clarify, that's the situation with the FDA so far. Finally, I want to finish by saying this. Some people have been saying, some doctors even have been saying, what do we have to lose? What do we have to lose? If it works, it's fantastic. If it doesn't work, we've got nothing to lose because we're going to use it on critically ill patients, ICU patients, Look, if the drug is going to be used on critically ill patients, right? ICU, ventilated patients, I think to give a drug that is not proven to work, such as hydroxychloroquine, can be very dangerous because in ICU, every little parameter counts. Your glucose, your blood sugar, just a blood sugar of 300, which might not mean much to a diabetic who's used to use his or her own glucometer and measure them and measure himself or herself. 300, they won't be worried about it. They know how to adjust it. They know what steps to take. But in an ICU patient, a glucose of 300 is a serious problem. In a patient with an encephalitis, with some neurological disorder, with a brain injury, a glucose of 300 is a serious problem. What I'm saying is that every parameter counts. Your PaO2, FiO2 ratio is very important. So to give a drug that is known to cause hypoglycemia, that has several side effects that are going to compound on the management of that ICU patient, especially if it's not proven to work, there is a lot to lose. Because it will exacerbate the management of the already difficult management of that patient. People say, what do we have to lose? But it's because they've never worked in ICU. The intensive care unit is a very complicated science. Intensive care, right? It's very complicated, it's very precise, it's very delicate. You cannot just give something that might or might not work. It can't be, And now, when it comes to the most critically ill patients in ICU, those that have a so far percentage that that's just sky high. I mean, so far, meaning the sequential organ failure assessment, that is just too much. I mean, for those that have reached that level, do you really think that hydroxychloroquine and azithromycin is going to work? Once you've reached that stage and everything has been tried and everything has been done, and you keep on deteriorating, and your ejection fraction, your ventricular ejection fraction is just so low, and your SOFA so high, and your PO2, FiO2 is completely, I mean, it's just so low that it's, by that stage, it's too late. You will not come back just by getting hydroxychloroquine. It's not a magical drug. Even azithromycin, because in the study, azithromycin was given to patients initially on hydroxychloroquine that then develop a pneumonia. By that stage, azithromycin, if you have a pneumonia, a multi-lobar pneumonia that is so severe that it pushes you to ICU, I think azithromycin is not going to be your first choice. By the time you are in the intensive care unit, intubated, you will have, I mean, the choice of antibiotics will be way beyond azithromycin. We're not talking about imipenems, carbapenems, and all those, and fourth generation cephalosporins, and we're talking about the big guns of antibiotics. That's it. Thank you for watching. It's been a very, very long video, almost 1 hour and a half, but it was necessary. I really wanted to talk about this, and I'm also making this video for myself because I'm going to download it to my phone. And tomorrow, when I see a patient that wants to argue with a doctor or a nurse about, please just give me some hydroxychloroquine and azithromycin, I saw it on TV, it works. I will also give them a link to this video and then invite them to, educate themselves and learn more about this whole situation, And look, thank you for watching. Thank you for giving me the time. Things had to be clarified because there is a lot of confusion, and some people are going ahead of themselves, and are talking about things that are not actually true, And the reason I wanted to make this video is because when I saw public figures, these are people that, regular folks are listening to, on TV, in the media. When I see these people misguiding people around the world, I think it's important to set the record straight, So with that, ciao, bye-bye.